happiness, prosperity, and we can all get back to some normality, hopefully. So for the last procedure of the year, I've decided to upload this patient who attended with bilateral, fully occluding earwax. It's a lovely gentleman, there's a teacher in a local school, has to normally get his wax removed every 9 months, I believe, but unfortunately, due to the current circumstances, he kind of put it off and his impaction is quite bad today. Made the cardinal sin yesterday of both submerging his head under water whilst having a bath and using a cotton bud, and he got the water purposely in his left ear, and you can see the lateral wax in his left ear is quite wet. That's where the water in the bath is come in contact. The deeper layer, so now we've removed the lateral layer of wax, the deeper layer has been somewhat protected, the water hasn't managed to get through. So I used the Jobson horn to remove the lateral outer half of the earwax. I'm now on the bony part of the ear canal, and this earwax plug is lodged. When I remove this plug of wax, you'll see the patient's ear anatomy. Everyone's ears, we have two narrowings within the ear canal. The first narrowing is where the cartilage portion and the bony portion of the ear canal meet, and that's roughly about 1 centimetre into the ear canal at the second bend. We also have two bends, so your ear is like an S shape. The second narrowing is roughly 0.5 centimetre away from the eardrum, and the ear canal narrows and then it widens back out and it creates a protruding ear canal near to the eardrum, and you have all these recesses. You have an inferior recess like a trench, you have an anterior recess which is like a little cravat adjacent to the eardrum, and when the wax is lodged beyond the isthmus into the narrowing of the ear canal, it's very, very hard to remove, and it will become more apparent later. And you can see here, I'm just using some suction, you can see some of the skin that I peeled, it's got some blood on it, although we didn't make any contact with the ear canal, so the patient's also got loads of skin adhesions. You'll see again that when we remove all the wax, the patient's ear canal is very, very dry. Not able to dislodge this wax using suction alone, so I've had no choice really but to use an ear hook, and I've managed just to insert it and glide it through the top of the ear canal, the roof, without making contact on the bony part of the ear canal, because that's very sensitive. So the bony part of the ear canal, the inner 2/3, is a thin layer of skin measuring 0.1 millimeters in thickness that lines the bony part of the ear canal, whereas the outer third, it's a thicker layer of skin, 1 millimeters in thickness. You've got cartilage, so it's flexible. It's not as sensitive as the bony part of the ear canal, and there's some muscle and some fatty tissue there. Although the ear hook didn't dislodge the wax, what it did do is dissect it. And once you dissect it, you can then go back in with a suction probe and try and vacuum some of this. But it's still lodged really deep against the eardrum, and you just have to be a bit gentle, because by putting pressure on this wax with the Zollner suction probe, you could accidentally, unintentionally be pushing this wax further against the eardrum, because it's already in the eardrum. And I don't know whether you can see, guys, the ear canal there, just where the wax is, there's a little cave that goes in. You're beginning to see that narrowing. This piece of wax, because the patient used a cotton bud, it's the best way I can describe it. It's like a piece of chewing gum that's stuck at the bottom of your shoe. It's a horrible consistency. It's very elastic, very sticky, and it's got loads of skin adhesion. You can see the skin just being lifted from the base of the ear canal there, a few strands of keratin. And what I'm doing with the Zollner suction probe, I'm just trying to get around the perimeter of this plug of wax, just to loosen it from the ear canal wall first of all, and dislodge these skin adhesions. Bit of wax is teared away there. I was going to put some olive oil drops in, but I felt the wax was on its way out, so by the time I put the drops in, soak it for 4 or 5 minutes, I would have just got this wax out, and it was completely comfortable for the patient. If it was slightly uncomfortable, I would have probably just put some drops in, but I was able to remove it without it. And I'm just trying to lift this plug of wax upwards over the ridge, the narrowing. But it's stuck at the roof of the ear canal, so I've just gone back in with the Zollner suction probe. I often find the roof of the ear canal is the most sensitive part of the ear canal for patients. So we just have to be really careful here and very gentle. I'm just getting the suction and pulling this forwards. You can see there's a lot of hair in there as well, so this wax is matted. When you've got hair that's matted against earwax, it's so hard to vacuum because you don't really get a very good suction grip. But I'm just loosening it. You can see the wax that's really deep in the ear. It's become visible now. I'm just loosening it. I'm trying to create an opening, so I'm thinking ahead what my next move is. It's almost like a game of chess sometimes. So the idea is just to create a gap there, a wide enough gap to go in with an ear hook. And you can see I've made the gap in with the ear hook, pulling this forward. It's still quite impacted, so even with the ear hook I'm pulling it forward, and it's a lot of resistance still because it's a really embedded plug, got loads of skin adhesions. Again, I'm just going to the posterior canal wall and the roof of the ear canal, just rolling this forwards gently. Got to be careful when I'm moving the ear hook. We don't want to lose control of it within the wax and then it flaying around in the ear canal and accidentally cutting the flesh, causing the ear to bleed. So the ear hook served its purpose. I've dislodged the wax, dissected it into small pieces, back in with a Zollner suction probe just to clear up the rest of this dry wax. You can see it's very dry. Again, it's just having to wriggle it a little bit, get rid of all the skin adhesions, and there we are. So when you're performing wax removal, you always got to think, it's a bit like a snooker or billiards player, you're thinking 1 or 2 moves ahead. Bit of dry wax on the attic, so the pars flaccida. So the pars flaccida is the top part of the eardrum. We can also call that the attic. The main body of the eardrum is called the pars tensor. The pars tensor has got some muscle fibres, so it's a little bit more elastic. The pars flaccida, the top part, is a very thin part of the eardrum, and that can get retracted. So if you've got eustachian tube dysfunction, so the tube that connects the middle ear, which is a cavity behind the eardrum, to the back of the nose, if that eustachian tube gets blocked, there's no air behind the eardrum, it causes the eardrum to get vacuumed and suctioned inwards, it gets retracted or buckles inwards. There's many different names given to it, and typically it's the pars flaccida, the top part of the eardrum, that gets retracted, and that can cause a retraction pocket. Dead skin can then collect in that retraction pocket and then develop to a cholesteatoma. So it can cause a lot of problems when you've got a retraction of the eardrum. Fortunately, this patient doesn't. Just using a Jobson horn. As I said, this wax is really sticky and dry, so it's really staining the ear canal. So just with a Jobson horn, just trying to remove this. This will just come out naturally anyway, guys. It's not even in the ear canal, it's just on the outer part of the ear, but so in this region of the ear, because it's on the outer part, you can just get a wet flannel. As long as the flannel doesn't go in the ear, we don't want to get, we don't put any inside your ear. You can just get a wet flannel, just because on the external part, that's fine. So this is the patient's right ear, a big plug of wax. It's a bit softer, just gone in with the ear hook, and there's a big gap at the top. You can see there's a lot of hair matted to this plug of wax. Managed to remove that one big large chunk there, but this wax, there's some remaining wax, residual wax on the anterior canal wall. So the anterior is the front part of the ear canal towards the nose. So if we're doing the right ear, the anterior part of the ear canal is on the right hand side. If it's doing the left ear, the anterior part is the left hand side of the ear canal. This soft wax is also adhered to some keratin, some dead skin, and you'll see that in a moment. So with a Jobson horn, I'm just getting in behind, you can see the skin that's attached to the ear canal. I'm going to loosen that just gently. This is just about on the cartilage portion where we are. If that was on the bony part, it would have been really uncomfortable for the patient. And there we are, we've just released this dead skin, and when we release the skin, the wax that's attached to it also comes out. So the patient's symptoms are completely alleviated at this stage. The patient came in, I should have mentioned this right at the beginning of the video, given the thumbnail, the title. The patient reported 95% deafness in the left ear. So this is the right ear, but in the first ear, the left side, reported 95% deafness due to that wax. He couldn't hear the Zollner suction machine. I've noticed a lot of people that do have wax when they come, and that suction machine is quite noisy. You could compare it to a hairdryer, or in between a hairdryer and a lawnmower. I wouldn't say it's as loud as a lawnmower, It's pretty noisy, and we're talking about the main machine. The external part, obviously, it's going to be noisy inside the ear as well with the suction probe. But the main machine, when it's operating, a lot of the patients can't hear it, so it's making me assume that earwax can cause a conductive loss of up to 50 or 60 decibels. Unfortunately, patients book in on an earwax removal appointment. It's a limited time, so we don't actually do a hearing test. As an audiologist, obviously, I do hearing tests as part of my day-to-day job. I've got hopefully some exciting news in the new year, where I will be able to dedicate some extra time to do some hearing tests pre and post procedure, just to get an idea of how much conductive hearing loss earwax can cause. A conductive hearing loss is when the ear canal prevents, or the middle ear prevents sounds from travelling through the ear canal or through the eardrum to the inner ear, where the organ of hearing is the cochlea. So that's called a conductive loss. The organ of hearing itself, the cochlea, is functioning fine. It's just the sound can't get through to the cochlea, to the inner ear, via the ear canal, either due to wax or infection, or if there's a problem in the middle ear with stiffness of the bones, what we call otosclerosis, or glue ear with catarrh fluid behind the eardrum. That's both ears. That's all the wax I extracted from the patient's ears, and I did weigh this. I believe you'll see that coming up in a moment, a still image. Just weighed in at 404 milligrams, so just under half a gram. Some wax that obviously did get suctioned up the vacuum into our suction liner. I hope you enjoyed that video, guys. Have a great evening and a fantastic start to 2021. Take care. Bye.